Good evening, everyone. Hope everyone is well. It's Thursday, so it only means one thing. We're back with the special guests. So tonight, just before we get started, those that can have cameras on, please do. If you can't, no worries. But if you can, please, it helps us get you involved with the call, and hopefully you feel more connected to the call as well. So, yeah, we've got a really special guest tonight. Actually, our first guest is not type 1, but in my opinion, will bring lots of value, and he's a bit of a legend. So, welcome to the call, Partha.
Thank you. Good evening. Thank you very much for the invite. It's much appreciated.
No worries. Thank you for your time. We really do appreciate it. So normally I've started every single one of these calls with the same question. Unfortunately, I won't be able to ask you that question because you're not a type 1. But what we will do is let's ask you, it'll be a bit of a twist on that. So normally I ask people to tell us a little bit about their diagnosis, but honestly, I don't really know a lot about you. So it'd be good to hear a little bit about yourself and how you've ended up in the diabetes space and doing what you're doing.
Yeah, so depends on how far you want to go back. I've been a consultant in diabetes. That's my training for about nearly 16 years now in Portsmouth. That's where I work. And it's good fun. I learned my trade up in the Midlands, then down in the south of England, and then finally a consultant job in Pompey. And then about, how long has it been? Doing a national role in diabetes, looking at type 1 diabetes technology for about 8 years now. So long career, and a few things done along the way. Yeah, and that's about me. So, training as you do as doctors, go through it, pick a specialty, and then, work your way through. And I've been fortunate enough to have the opportunity to be in the position that I'm in. And yeah, so that's where we all are at the present moment after so many years.
Amazing. So why was it type 1 that you picked though? Or diabetes? Why was it that in particular that you wanted to pursue?
Well, two reasons. But basically, when I first joined the national team, which is in 2016, I think what I picked up at that point, there was a lot of work and a lot of discussion on diabetes, which generally ended up meaning type 2 diabetes, if that makes sense. So you would have conversation, you go to meetings, people would talk about we're trying to prevent diabetes, and you understood that they're generally talking about, diet and how they were going to do low calorie diet and low carb diet, all the sort of stuff the research was coming through. And I think my view is that prevention isn't just that. Prevention is also prevention of complications. If you got something, for example, type 1, which you have due to autoimmune, then the prevention in that case, you can't prevent it from happening yet. But, if you've got it, then you can prevent complications from happening. So that was one of the reasons, because I wanted to, and technology access in those days, you look at other countries. Used to go to conferences, and we were like one of the last in the pack in Europe, and way behind. And you used to go to conferences and they used to go, oh yeah, you're very good at the science, you just can't give it to people. So I think that was one of the drivers, and it was a nice area to sort of pick and run. And I think after that, over the course of time, also the bonding with the community has been really good. So I think I've learned along the ways. You probably learn more about type 1 diabetes than you ever do from books by interacting with the patients in clinic and the people you know. So yeah, so that's been mostly, and that's why I've stuck with type 1, because it's been a nice little thing to do and trying to get it across, and all the other bits in type 1. There's so many gaps in type 1 diabetes care. So yeah, it's been one of those things. So it's quite nice to see us, talk about lots about the technology where we have got to after so many years. And you go to international conferences and it's a big difference, let's say, from where we were in 2017, 18. So lots of people talk with respect about the UK, which is nice. So that's nice.
Yeah, no, definitely. I mean, even in my short lifetime, like, the technology has improved massively, but equally, more importantly, the access to technology has obviously got a lot better. And hopefully, I think everyone on this call would have access to a CGM if they want, which is amazing. It's an amazing position to be in. So and that's through some of your work. So we do appreciate that. Is much appreciated. And often I see, I see on your social media a lot of the time, I think us as type 1s, I think we can be very, what's the word, but we're very appreciative. And I often see like really like nice posts of, your patients or people that might have reached out to you and said thanks. And I think that must be quite, that must be quite nice to receive that, on a daily basis.
Listen, it's the best compliments. I've already said that publicly, right? And I've had nothing but love and respect and lots of kindness from the community. And I think some of it is because I try to be as honest as possible. I will not come out and say everything is going to happen tomorrow. And I think it's been a journey. When we did the Libra and the CGM, I kept on saying to people, give it time. I'm working through it. And I've tried to help people when they reached out. I've said, look, I'll try my best to sort of phone up some people and stuff like that. So I think the Type 1 community has been pretty universal. I mean, there'll be issues and complaints about system and stuff, but nothing personally directed ever. And I've been doing this for a long time. So I always say that to other national leaders as well. If you engage with your communities, you will actually find a way through, because it's the patient voice. Don't forget, that's driven this through. It's not policy. It's everybody in NHS England and other circles knows where I sit with people living with type 1, which is quite a powerful place to be in.
Yeah, no, I can imagine, definitely. So that leads me quite nicely onto my next question. And with everything that's going on at the minute with hybrid closed loops, and obviously there's lots of stuff in the press and that sort of thing. If you had to give some advice to someone, what would it be in terms of, would it be to press their team or to be patient, or what would it be?
None of the above. I think what I would say to them is that, first of all, look at the criteria. Do you qualify for it right now? And if you do, I think the conversation to be had with the team is that, have you got a plan as to when I would get it, right? And every team is supposed to now have a plan, a batting order. So when people go like, oh, children, but children under pediatrics, that's not the adult team. The adult team should have a plan from 19 up. And the plan could be, depending on your local region, could be, I want to give it to people whose control is the worst. It could be, no, I want to give it to people who are already doing well. It could be, I want to give it to people who are already on a pump. So it's just a question of switching them two together. But I think every team has to have a plan as to what are the plan do in year 1, then year 2. So I think that should be the question, rather than saying, why am I not getting it tomorrow? I think the question will be, okay, this is where I am in the batting. Do you know where I'm in the batting order? Because everybody should have a batting order place. Now, if they say, look, we reckon you will get it in 12 months, but it could be earlier if we can move things quicker. So one of the things we're trying to do to help people make things quicker is to say, why don't you work with the industry, right? So my chosen option would be, if I see somebody in clinic and I say, right, they want to have a closed loop, I would say, what do you want, to give them all the options. And if they say, look, I want this particular loop, then I should be able to phone the company up and say, put them on it, give them the training, get it done. So next time I see them, they're on it. So that's a much more sensible way of doing it. So that's, people need to be a bit more pragmatic, rather than saying, I just don't have any staff. Of course we don't have staff. That's why you reach out to other people to help out. I think if people are clever about it, then they can definitely get things moving quite quickly.
Yeah, it's a really good point, actually. It's one I've never thought of, to be honest, because I mean, most companies will have reps that will go around and do that as a job, won't they? So why not utilize that?
Yep, started on, and they've got nurses working for them. So my view would be, and you can do it in a group.
Yep.
Let's say 5 people have chosen tandem. You say to tandem, we've got 5 people who want to go on your tandem loop, 5 people want to go on a Medtronic loop. Put them on a group and say to the company, put them on, and let me know when it's done. I mean, it will be in their interest to do it as well, won't it?
Of course, yeah, of course.
So they will, and that's the conversations we have had with companies to say, why don't you help us? And I think that's what I've said to Trust, is that you can't say that we just don't have the staff. And we're going to get some money for staffing, but just money isn't going to solve it, because there isn't enough trained nurses and doctors out there. So let's lean on other people to try and help. And I've asked people to think about expert patients, people who are really well trained, know about closed loops really well. Why don't you utilize them to come around and help you? You can do so much stuff.
Yeah.
Just people need to think slightly differently rather than being rigid in their approach, I would have thought.
That's quite refreshing. Yeah, I mean, definitely, because the rigid, in my opinion, the rigid sort of approach that is presented at the minute, I think it doesn't work, does it? It's not feasible.
Well, that's what we had the problem with CGM in year 1 and 2 before we sort of stepped in, because they were like, oh, you have to go to this hospital and then you have to be trained and you just sit in a room and learn. And I go like, not really. There's YouTube. If you a link, they're all adults, right? So the way I used to have done, nowadays everybody's on it nearly, but I would say to somebody, here are the link. One is to a Libra and the other one is to a Dexcom. go home, have a look. And first of all, let me know if you understand it. And second of all, let me know which one you want. And if you say that I actually really could do a bit of help, but then you put the people who need some help in a group and you do it in a group.
Mm.
I can tell you, the vast majority goes, yeah, got it. It's fine. Let's put it on. Let's start. And you learn it along the way, don't you?
Yeah, of course. Yeah,
That's
of
what you
course.
do. So I think people, as I said, those things have stopped in the past before my time. I think that's also one of the reasons why pump uptake has been so low.
Mm.
Because people insist you have to go in and spend 5 days training about it, and you go like, okay, well, that's all lovely, but it's becoming a barrier to people getting it if you're doing it that way. So be a bit more, I don't know, modern 2024 rather than 1924, whatever.
Definitely. No, it's, I completely agree.
Mm.
More of a more dynamic approach. So let's see. I
Mm.
mean, hopefully we see that.
Yeah.
Do you see, apart from that sort of the sort of that role in that issue, do you like foresee any problems with people going on pumps? Like, do you foresee any problems with it? Like,
Oh, of course. I mean, that is the NHS, right? There'll be 4 groups of people you will meet throughout the country, as having done this dance now before 3 times over, one with pregnancy and then, of course, with the whole Libra thing. I can tell you what will happen. There'll be a group of people, consultants and teams who will go like, brilliant, I love this. I want to put people on it and just come along and we're ready. When do you want to go? And have a plan. And they're ready now, right? They're just chomping at the bits. They just want to start, right? They're just saying, Partha, just release the money and we're good to go. That's group one. There'll be a second group who will go like, oh, okay, well, what's the data say? Is it allowed? Has our system given the green light? So they're looking for official approvals, which we will help them with. And they will say, oh, my system is doing this. So so the reason for not starting in straight in December, because we're getting all the systems to agree, not get into a position where we have to go in a pitch battle with everybody, which we did with Libra. So we want to start when everybody's going like, yep, okay, we're ready. We have a plan and go. There'll be a third group of people who will do it because everybody else around them is doing it just out of shame, because they'll just go like, oh, this is a bit embarrassing, right? And which we had. But there'll be a fourth group of people who will say, I'm not going to do it because, in my view, type 1 diabetes needs to be done by counting your insulin on an abacus or something like that. So then our job becomes to try and tackle them, right? And just say that, because my view, and I've said this to lots of specialists already, that if in 2024 you don't want to do hybrid closed loops, then you should think about whether you should do type 1 diabetes care, full stop. So, that's part of your development, right? You can't turn around and say, well, when I was in 1980, that's how I did it. But well, it's not 1980. You're just providing poor care if you're saying that. So those are the conversations we're having at the moment. So, yeah, I mean, pediatrics, as you all know, are ahead of us because of their desire to put kids on it first. So we need to get adults to that space. And that's why, to be honest, that's why we have a 5-year plan. So, yeah.
So I get from what you said there, I guess that's where the sort of, this postcode lottery element comes in, because it can be a little bit like that, kind of.
It will be. And I think that's what's taken us a good 4 years to crack that with Libra, cut past the postcode lottery, and now everybody's got it. I suspect it will take us a couple of years with closed loops. It will be shorter because I think the reputation is built and everybody knows where I come from. And this time we have asked everybody to submit us a plan. And if they have submitted a plan and there is money, new money, not saying just spend it from your existing pot, then I think people will have to really strongly justify why they're not doing something which actually is a legal mandate. I mean, Libra wasn't a legal mandate. We forced it. But this one's a legal mandate. You can be taken to court if you don't do it. So,
yeah, I think it's exciting time, isn't it, for people, that people that are perhaps been struggling with their, their team, and this is on the horizon. So I think it's an exciting time to know, in the next, 18, 24 months.
People need to know their rights as well. I think that's very important. People get fobbed off by the system, and a lot of people need to know it's a legal mandate. You can't turn around and say, I'm not doing it. So that's why it's called a nice TA. Technology appraisal is a legal thing. People have gone to court in cancer care and cardiology and won it. So, and we've told that to everybody. System is like, you can't duck this one, I'm afraid. So,
Henry, have you got a question?
Yeah, absolutely. First of all, thank you for kind of joining us today. But as Andrew said, there's already some kind of love coming in the chat for you. So everyone's appreciative of you giving up your time as well here. But you talk about kind of the there is a legal mandate here, and I was intrigued to know about the 5-year plan and whether or not that was a public plan, and whether or not there was a requirement on trusts to publish that. And make it publicly aware.
The 5-year implementation plan from NHS England is public, right? It's there in the public domain. You can have a look. We have predicted what we're going to do, and there's money. That's why we calculated the money. And local systems absolutely are submitting plans. So one of the things sort of tightening up is to make sure that there are now 42 systems, ICS as we call them. I want to see all 42 have submitted. And then it stays with us. And if somebody then suddenly, has a change of mind, we just publish it and say, this is your official plan with money.
Okay.
And I think the problem also is that if they don't, so we got money, and if they don't spend it, then that's silly, because why would you waste money? That makes no sense, right? So that makes literally no sense in the present NHS, where people are crying out for any money. So yeah,
But that's kind of on an ICS and ICB level. Well, same thing here, but looking at their kind of regional plans across the larger areas. But is that down to individual trust? For example, I was thinking about what you said earlier in terms of a patient to go in and have the conversation, and
no,
I'm rewinding myself back a little bit, because I'm going into the time when I kind of fought for my pump and my CGM, and it felt like I was having to go and really fight for that. And I'd much rather things be collaborative, but I'm just kind of going.
I think I've always said to people, you escalate, you involve me where needed. I've always stepped in when it's come with Libra. I think if there is no trust that I'm aware of, as said, who can't do it. I think that's important. Because, for example, if people will come up, as I said, if they're group 4, where they just don't want to do it, then they're coming up with excuses more than anything. They can't say no, but they're coming up with reasons. So then people will say, well, I don't know the staff. And then the question would be, so what staff do you need to put people on who are already on a pump and a sensor? That doesn't need staffing. That needs basically flicking a switch, right? What staff do you need if industry have come around and said, we are ready to put them on it? Because industry will. That's the deal we are striking with them on the money side of things, because that's what we want them to do: provide 24-hour cover, provide onboarding support. We want that from them this time around. So they, if you're on a pump, you are looked after by the pump company, not just the supplies. That's what we want. So yeah, I mean, I think it's much more difficult. We're trying to tighten up as much as possible the questions about why they can't do it. But all I will say is that this time there's a different feel to it, I think, compared to what we had with Libra, because I think because we have got money attached to it, and there's a lot of momentum around it, and people with type 1 are also much more switched on. I think, as somebody said to me, I was said in a meeting, oh, you encourage people to give us trouble. I said, well, it depends on your definition of trouble, isn't it? Right? They're fighting for what is due for themselves. They're not trying to burn down your house or something like that. They're just asking for something that they're eligible for. So, if my presence allows people to raise that voice, yeah, why not? Absolutely, go for it.
Amazing.
There's a couple of questions in the chat, so let me read them out, Partha. So the first one's from Matthew, and it's, what was the deadline for the ICB's plans to be submitted?
Where has it got? Where are we now? 4th of April. So the deadline is in the next 7 days, because they're submitting the data because here's the thing. So we didn't have all the data from everybody, believe it or not. Not everybody told us how many people were on pumps and sensors. We sit and go like, okay, well, without that, I can't give you the money. Because if I don't know how many people are not on pumps, then how am I going to give you the money? So that's finishing on actually on the 12th of April. So so far I haven't heard any negative, but once it happens, it's done. We want a 42 out of 42. That's a wholesale, and that's the plan.
And just to chip in on what you said there, Partha, I can completely see that data frustration. I work in healthcare, I work in data, and I've seen the technology register from one of the largest trusts in the UK. I won't name them or shame them. But that register, is a spreadsheet would be the best, I would call it. With no standard formatting, no way of just easily pivoting. Right, how many have we got on active current subscription contracts? Great.
So to basically take it past that, because people then go, oh, we don't have any money, right? So we've actually given £2.5 million. So every area is at £60,000. That's a lot of money, right? To do only one thing, which is collect data. I mean, believe it or not, we just said, if you can't do anything, just put it on a blinking spreadsheet and send it to me. That's all I need. I need something. So there is literally impossible to give a reason as to why they couldn't send the data, if that makes sense. Even something as basic as putting on a spreadsheet, if you don't have an IT system. We've also asked them to think about, if you don't have an IT system, here's an opportunity to procure an IT system, right? Here's some money with some, so you could, I think, as I said, if people want to find a reason why they don't want to do it, they will find a reason. And that's where, so I'm always conscious. I always conscious of group 4, because as I was saying, group 3 is a group of people who will only do it because they're shamed. So for that, we need the maps, which will come out very quickly. I'll be putting out maps, green, red, black, or amber. And then I'll invariably get a call from regions which are in the black saying, why would you do that? Don't do that. That makes us look bad. I'll just go like, well, there's a very simple way to do it. Just turn yourself green. Just do it. It's very easy. So that works. So that's fine. Will this money be ring-fenced? 100%. It's ring-fenced. Can't use it for anything else. It's locked. We're blocking it up, so they can't be switching it off and do any other. And to be honest, that's the reason we're going to pay them retrospectively. Even better. So we have said, send us a bill in quarter at the end of your first 3 months, and we'll pay you. So even nice. So can't spend it or anything else.
Right, there's another one in the chat. So do you know anything about provision of HCL in other regions of the UK?
Mixed bag at the moment, if I'm honest. Scotland actually has a policy much earlier than us. I think Scotland have struggled to roll it because of lack of money. And we are in conversations with them. So I think tactically, I've always said there's no point in releasing a guideline if you don't have money with it. That's my fundamental belief, because the NHS is struggling for money on all quarters. And I think when you go to funders and say, fund this, they'll have to take it out of somewhere else, right? And literally, they'll be taking out, for example, asthma care to, look after type 1 diabetes, which isn't fair on the whole population. So Scotland have got caught in that because they've got a policy that the people should have it, but they don't have the money. So the only way they can have the money is taking it away from something else, which is a problem, while we have money. Wales, same problem, but England and Wales tend to work together quite closely, and the number in Wales are much lower. So I suspect that will go. Ireland is a fair bit behind, I would say. Fair bit behind on that one.
Very interesting. Has anyone got any questions? So you can either unmute yourself or type in the chat as people have been doing there. Not all at once. Go on, Matt. Yeah, go on.
Hi there. Thanks for coming on today. My question is, I recently went to a pump like day, and they were talking about closed loops at in Essex, and they said to me that their policy hadn't been written up yet by the powers that be, so I couldn't be considered for a closed loop. Is there anything I can do to kind of push that along, or do I need to?
Why wouldn't you be? Was it because you weren't the criteria?
Well, they don't know what the criteria is, basically, because this parent policy hasn't been written up yet.
It's been there since the 19th of December. It's out there. It's called the TA 943. It very clearly states who's eligible.
So if I get that and kind of throw it about in the office.
Yeah, just basically, it's a NICE. You can Google it. It's called the NICE TA 943. It gives you a criteria, and that's the criteria. It's been there in the public domain for 3 months now. So the understanding is that if you qualify for it, you qualify for it.
Okay, and there's no way they can. I mean, that's a national thing, so they can't.
They can't tweak it,
or they can't kind of add caveats to or anything like that.
Not at all. There's no caveats to that. It's quite straightforward.
Okay, all right, brilliant. I will give that a go. And
I think just on the when you say there's no caveats, the caveats, I think there are some caveats, and correct me if I'm wrong here, Partha, but essentially the caveats is that they've been given a 5-year plan to roll it out. So it could well be that depending on where you fall in terms of their local guidelines, that you could be at year 5 in order to be, but it's not that you're not eligible. You just might not be, be able to get it on day 1 straight away.
Yeah, I mean, I think the 5-year is a stretch target at the end of the day, because if you look at the numbers that are in each region, you should be able to get there much earlier than 5, right? Because literally, that's the thing that type 1 diabetes centers are supposed to be doing. So I think the run is over a 5-year period. So the caveat there is, yes, they may say not today, but I think that's the question I said. I think that's where you need to find out. So in your plan, where do I fit in your, planning? And, will you be ahead of schedule? If you're ahead of schedule, will I be brought forward? What's the timeline? What's happening? That sort of question. So I think that's important to have those sort of discussions, I would say.
Interesting. Okay. Could they just thinking out loud now? Could they be talking about the fund? Could they? I'm talking about Matt in what Matt said there. Could his practice be talking about the funding and how they access that? Could that be what they mean? Not the actual, not the guideline itself, but how they access the funding.
Possibly, because we haven't hit the green lights on the funding yet, because we could hit it today, but then we won't have all the pumps and sensors in there, and I don't want to go in with only 4 loops in there and 4 not, if that makes sense.
Yeah.
Because I would like to offer all the choices, and I don't think it's acceptable for a company to say that we can't, do the price changes that others are doing. So that's the pressure that we have got on all the companies at the present moment to say, I'm sorry, but that's what we need to get to, right? Because if 4 companies can do it, the others can as well. So so hopefully that will conclude in the next few weeks, I would have thought. We're nearly there. So yeah, we're just pushing them a little bit more. Got some more meetings next week. So yeah.
Perfect. Any other questions?
Hiya, I've got a question. I'm not sure if you'll be able to answer it. It's a bit of a cheeky question about the suppliers and the tech that's available. Do you have any favorites in terms of how the tech works? Maybe in terms of accuracy of algorithms and such? Any inside info?
No, I mean, to be honest, if you look at the algorithm data, right? So I think it really boils down to a lot about your personal choice about the tech, rather than the time in range. They're all a bit of the muchlets. You can slide things. I mean, in pregnancy, I think a couple of them are licensed because they've got more tighter data, because the data has to be much more tighter. But beyond that, I think it depends as to what you really like. Is it the customer service? Is it the fact that it's got tubes? Is it the fact? So don't forget that lots of people go, oh, I don't want a tube pump. But actually, tube pumps are preferred by a lot of people because you can take it off, right? You could, for 1.5 hours or so, an hour or so, you can actually be free of it and go swimming or whatever you want to do it. So because it lasts you for that period. So loads of people are very different in what they choose. And then again, do you want one company to hold everything, the supplies for you, so you don't have 2 different sources coming at you if it's a mixed one? So I think that's what it boils down to in the end. I think a lot of people prefer the slickness of the tandem. Some people go like, don't like that. It's a bit too heavy. So it depends. It really boils down to personal choice. Clinically, I don't think there's a huge amount of difference between, I mean, the companies will say some of them are best things in sliced bread, but there's no massive differentials between them, right? At the present moment, especially along the top ones. If you talk about Medtronic Tandem, Omnipod, and stuff like that, they're all continuing to improve. Quite tight the ranges are at this point of time.
Do you mind if I follow on from that? Because it kind of leads me on to the next question, Partha, which so one of the questions that I had was about kind of rewinding a few years now to kind of when this started and when the data was starting to be collected. Obviously, there were pilot studies, back in the and looking at kind of the pregnancy side of things predominantly, and also the kind of young pediatrics. And I was intrigued to know how much when kind of decisions like this are made, how much are we looking at kind of quantitative data, and whether that's short-term quantitative data, long-term quantitative data, versus that qualitative kind of side of things, and whether or not that is ever considered, how much weight that carries in relation to the kind of quantitative versus qualitative.
Quite a lot. I mean, I think over the course of time, that's definitely changed. I think previously it used to be, just give us the numbers and the A1C and stuff like that. I think nowadays quality of life and metrics have been quite important. I think that's been one of the big drivers as to what helped NICE take closed loops over the edge of what can be funded by the taxpayer. So it was quite powerful, especially the data that we had from carers, parents, and all that sort of stuff. So I think it's getting much more understanding as to, it's a very important part of people's lives, and it actually changes the dynamics of your quality of life. So that's definitely seen in a different light compared to what it used to be.
Yeah. And the reason that I'm asking that is because for me, it's the quality. I've been using a hybrid closed loop now for probably about 4 years. And it's definitely the quality of life element that for me, where the huge swings are. And my timing range is definitely improved.
Yeah.
And long term, I'll see those quantitative gains, hopefully, in terms of long-term complications and things. Yeah. But for the next 40 years, it'll be those qualitative things that really make a world of difference to me.
Always. Absolutely. It will be. I mean, I think the important thing is, if you improve quality of life and you're better, then your control will get better. That's what we see in clinics. All the quite regularly. So I think that's, that sort of goes hand in hand. If you can improve quality of life, the rest of it falls in place.
Do you mind me just, whilst I'm still muted, do you mind me just kind of rewinding a bit earlier in your life? I'm intrigued to know a little bit about you in terms of, there are many people who go down the same path that you did and kind of went into a specialty, then maybe got the teeth stuck into a specialty because they really enjoyed it, whether that's, looking at diabetes or their endocrinologies and things. But not I think there are very few people that are as passionate or kind of advocate in quite the same way that you do for their patients. So I was intrigued to know, where does that come from in you? Do you think that's just a personality character of you, or was it a particular event, or?
Well, partly and partly not. Partly, I mean, I think, for me, I think people see leadership roles as very different things. You do leadership roles for different reasons, right? Some of us do it because you want to have it on your CV. Some of it makes you feel good about yourself. They're different roles. For me, leadership is always about outcomes. I want to look back at the legacy and see what you have left behind, and have you given it 110%? You don't have to win everything, right? For example, if you follow any football team, there'll be lots of football coaches who haven't done well, but the fans love them because they've tried. And that. You sit there and you know what? With everything you had at your disposal, you gave it all for our club, and we love you for that. And that's a very good example of leadership is not just about success. People need to see. So I think to your question, I've seen it as, I've always said it's a job, and I want to finish the job. And I think it's also my personality in the sense it's never bothered me as to who's got upset by my style as you're going along, because people have said to me, oh, sometimes you can be very cocky and this and that. I say, yeah, but I'm never that with somebody with type 1. So, with them, I'm always trying to be humble and be honest and open. Yeah, I can be sort of abrasive with people who are stopping care or not doing what I'm asking them to do. But, and I think it's one of those things, and I'll give you a very good example of that. So there was a particular region, I'll tell you, it was Cambridge, who does a lot of academic papers, but was one of the last in the country to give people Libra.
Well, that shocks me.
Yeah, and I published, and they're brilliant at academic papers, right? They're one of the best centers in that, but they just didn't give anybody Libra. They were the lowest in the country. So I published a map and said, okay, this place is just rubbish. So I got lots of emails saying, oh, we feel really bad now. And I went like, oh, okay, all right. So I had a meeting and the chief exec said, well, we need to remember we need to be kind to each other. And I said, well, see, this is silly because you need to be kind to the people living with type 1. That's your bloody job. Why are you asking me to be kind to you? Right. And secondly, if this was some sort of like kindness village, then we should go on a retreat, right? We're all doing jobs paid by the taxpayer. So I think I'm very happy to say that publicly, which lots of people will take it, and I think people do that all the time, right? Be kind, and you go like, well, I don't understand this. We're just asking you to do a job. So I think my leadership style has always banked on that, in the sense of I would say, look, I'm doing a job to the fullest of my extent. And that's my style. It's very sort of, 100 miles an hour in your face, but I want to get the job done. So
well, there's a few comments in the chat. I think, pragmatic, refreshing. Some of the other things, so lovely to hear this approach. A few comments in the chat there that kind of all lean on from a patient's perspective. That's exactly what we want to be hearing is someone as passionate as you who doesn't have a strong family connection perhaps, or doesn't have a personal goal other than their own kind of pride in their own work. And I wish the rest of the UK, of every working kind of person in the UK, took as much pride in their own work as you do. But I think one of the things that at DPC that you talked about, I think you were talking about kind of the inequalities and by inequalities I mean looking at black and ethnic minorities and the and kind of the balance there in kind of what regions were doing good and not. And you kind of you turn around to a room of a few hundred healthcare professionals there, if not reaching up to 1,000, and kind of said, take a good hard look at yourself. The numbers don't lie. The numbers, let's use evidence. And make decisions based on the evidence. If we've collected the evidence, let's use it. Let's not just collect it for the sake of collecting it. And then let's act on it. And I think that's refreshing to hear as well, that someone that goes out of the way to go and collect the evidence, and then present it back and put it in people's faces, to try and get things changed and turned and moved in the right direction.
That's the plan.
think there was a hand up. I think it was it Matt?
Yeah, just wanted to say thank you so much. Hearing a consultant talk like that's really, really refreshing because when I was diagnosed at 16 years old, I was told basically by my consultant that you're going to pretty much stop playing sport, don't do anything else. If you don't control this disease, you'll be blind and you won't be able to have kids when you get older. And that obviously scared the living daylights out of me. So it's really nice to hear a doctor talk to me. I've not had very good positive experiences of doctors caring for me with my diabetes. It's always been the diabetic nurses that I've had a positive experience from.
Yeah.
So to hear a doctor say that is really it's really just really refreshing to hear, and that you're advocating for actually good care and to being passionate about it when I've never ever had that experience before in my whole life. And I'm 42, I think. Sorry, diabetic relating to dementia. No, joking. 42. And I've never had that experience in my life to hear a doctor have a positive experience and a passionate experience about giving good care. So I just wanted to say thank you so much for kind of saying that. It means a lot to people on the call.
It's a pleasure. Thank you. Thank you. Well, I think that's why we do the work that we do around language matters and all that, just trying to tell people and I've always said this in meetings, we see you only for 0.01% of your life, actually. And the minimal you can be is nice. You don't have to do anything magical. Just be nice and people will come back to you. We always know that. It's very well recognized. So I'll give you an example. People always talk about, teenagers are just rubbish and adolescents. Well, they're not coming back because you're not making the clinic visits worthwhile, man. Right? If you're going to be sitting there and lecturing them on what you should do better, they're not going to come back. That's how it is. So, if you want them to come back in a long-term condition, the only way you can improve their care is by getting them to come back and developing a relationship. It's the key. So, but I think that's also why we are sort of trying to promote more of the technology, because the self-management is the key. If you get good peer support and good technology, which will help you with self-management, then you're more than halfway there. And then if you get a good clinician, nurse, doctor along the way, then you're made. So I think that's the ideal trio. And in the absence of the third one not always being available, I think the plan is to try and make the first two as much as possible. So yeah.
You mentioned peer support there, and I just wonder whether or not you think there's a place for that to kind of take more of a forefront. I know that we've seen it kind of added to the kind of Diabetes UK kind of slides and projects, but in terms of clinics and the way that diabetes is managed, whether or not you think peer support could actually be mandated in the future and
it should be. So that's the reason we did the peer support sort of principles, because you want people to have peer support groups. We want every center to have an access to a peer support group. That should be, as soon as you're diagnosed, you should be given the option. You might be somebody who doesn't want too many people telling you what to do, but you can choose to go back to it later. But at least you should be given there along with your, with your sensor and your insulin and your education. You should have access to a local peer support group. That makes sense. You would like to talk to people who live with it all the time, right?
The reason I'm asking is, I've been to 2 local healthcare trusts and kind of said, look, I want to actively run a peer support group. You're not running one here. I want to run one, and I get pushed away and go, "Oh, we're not interested in doing that. It's not part of our core responsibilities at the moment." So it's not in our.
So I think so. One of the things I want to pick up after this is exactly that. I want to see why every center doesn't have a peer support group, and it makes no sense. I mean, the clinicians don't even have to do anything. It's basically get some people get together. And what do clinicians worry about? They say, they're going to give some advice which might kill them. So I always go like, look, if they want to kill themselves, they've got insulin. They don't need to do complicated stuff like giving each other bad advice, right? So stop being so worried about everything. I think people are too worried about the legal implications of what will happen. So you go like, well, it's a group, right? Let them talk to each other and see how it goes, right? People with diabetes will have much more learning and understanding than I would, and that's fine,
Or at least enable people to get in contact in some ways, even if you're not involved, at least try and facilitate it in some way.
You're there more than I would, right? So it makes full sense to me. So that's something that, and to be honest, peer support groups will be absolutely key to the closed loops rolling out, because it's when you bump into each other going, why didn't you have a closed loop? That's what happened to CGM. People are going like, why don't you have one? So people go like, oh, that's a very good question. So that sort of stuff, I think, is quite important. Sort of go through. There's lots of exciting stuff coming through that will happen. Even immunotherapy, people are talking about all of those. Those are exciting stuff, I think, coming through. So we shall see how it all plays out.
Well, once the dust settles, I'll touch base with you because I've got a few ideas I'd love to run past you. But
please do, please do, please do.
Go on, George. You've got your hand up.
Hi. Hi, Partha. Just want to start by saying, obviously, thanks for all your work, particularly on the national level. I was unfortunate enough to be diagnosed last year, and also lucky enough to get slapped with a CGM sort of day one of diagnosis. So,
excellent.
So thank you for that. Just a question, really. You mentioned sort of earlier on, you mentioned there's still sort of gaps that you see in sort of type 1 care. Other than obviously what we've been talking about with sort of hybrid closed loops, just out of interest, what are the other gaps that you sort of see at the moment?
I think the quality of care. I don't think everybody's trained enough properly, if you ask my honest opinion. There'll be some centers which are. So let's give you an example. If I develop type 1 diabetes, I know exactly who I want to see, right? Bang on, eyes closed, I know who I will see. But not everybody has that information, right? So then it's potluck. 100% potluck where you are. So I think that's the thing. It shouldn't be down to I know who's a really good doctor and who's going to honestly give me the best care ever and is kind and all of that stuff. But not everybody has that, so it becomes a bit like a draw luck of the draw as to who you get. So that's a big gap in my book, and that definitely needs improving. I would say. So that's I don't think all specialists, and I'm not talking about primary care. I don't think all specialists know how to do type 1 diabetes care properly, even though they're trained in it. I don't think they know how to do it. So that's important.
Thanks for that. Any other questions before we
I'll just give you one example of that. So people always talk about deprivation, right? People say if you come from a really poor area, your control is poor. So here are some facts for you. It's not in type 1 diabetes. It's dependent on the quality of your local hospital. It's got nothing to do with your postcode. You can come from a really rich area and have a really shit center and poor care. And you will all know this. It's got nothing to do with your postcode. And that's a phenomenal data in this country. And we've got some really deprived areas, but who have got some unbelievable superstars in their centers. It could be a nurse, could be a doctor, whatever. And they have changed care in the local area. So that's an important example of what I always say.
Oh, thanks for that. Is there any other questions before we wrap things up? Amazing. Well, look, Partha, thank you again for your time. It's very much appreciated. I learned a lot there, so thank you.
Pleasure. Take care, guys.
Thank you. Take care, Partha. Cheers.
All right. Bye-bye.